This starts the series of the cardiovascular system, going through some of the anatomy and also physiology. And we're going to be getting into a lot more patient examples and case presentations for making this more of an applied anatomy section. For this topic today, it's going to be talking about just an overview, the function of the heart, the structures within the heart, and some of the pathologies and some of the cases are pericardial effusion, endocarditis, and brachial artery embolus. Some of these are actual patient examples. So looking at the physiology as a whole, it is a continuous loop, circulatory system, continuous loop. Everything has to be continually moving forward. If not, if blood gets stagnant at all, if it's not moving at all, like you'll see in atrial fibrillation, it starts forming clots. So that's what the pump's job is to do, always keep it moving forward. And the valves in particular keep it from the forward flow. As a heart squeezes, blood is forced to go only one direction, so one-way valves. So the heart is pumping oxygenated blood to feed oxygen to the cells for all the body cells. So how does the heart muscle itself get fed? By passive diffusion of oxygen, by coronary veins, or by coronary arteries? The answer is coronary arteries. They're supplying blood to all the three layers of the heart. The epi means upon, it's the outermost layer of the heart. And then the myocardium, which is the muscle layer here. And then the endocardium is the very most inner layer. And this is an image showing where the coronary arteries are evolving or coming from the base of the aorta. So this is the main points about the cardiovascular system, showing how the heart is a double pump. The blue is showing deoxygenated blood, the red is oxygenated blood. So a double pump is parallel pumps, separate by a septum. So it's 4 chambers, everything is moving forward. This is showing the forward flow coming through the ventricles and out the pulmonic valves and the aortic valves. CPR is artificial pumping. So if a person goes down, their heart stops beating for probably an arrhythmia, you have to take over the pump of the heart, and that's what effective CPR is. This is where knowing your anatomy matters. Next question, why does a person have to be completely supine, lying flat on their back for effective chest contractions? Is it because you have to be able to be breaking ribs to be effective with CPR? Or is it to compress the heart between the sternum and thoracic vertebra? The answer is to be able to compress. This is a lateral view of the heart showing the thoracic vertebra behind, and anteriorly is the sternum. So essentially, effective chest compressions are pressing the heart down between those two structures to create effective cardiac output. Okay, let's go through a little bit more of anatomy. This is showing the heart looking from the left side. So this is the aorta, the aortic arch, pulmonary the pulmonary artery. Okay, so the pericardium is a sac that surrounds the heart. And the image that's the best image I found is this image of a balloon that's kind of been inverted, like a fist coming into the balloon. And within the layers of the balloon is the pericardial fluid, and that's there to provide lubrication for the heart to be able to move. So the heart is contained within this sac, double layered sac. A cadaveric specimen that's showing a nice dissection. It's showing how these are collapsed lungs, of course, off to the side, and the pericardium is reflected back. And it's pretty thick structure. This is also a video showing the pericardium is around here. So it's pretty clear structure. And this shows how the heart, when it pumps, it's not just one direction. It's a twisting and a squeezing. So the pericardial fluid allows that to be able to do that motion of twisting and squeezing. So the disease presentation to start. Pericardial effusion is when pericardial fluid gets built up within this pericardial sac. And normally the pericardium has a way to kind of lubricate continuous circulation of clean, fresh pericardial fluid, kind of like cerebral spinal fluid. So that's constantly moving in and out, cleaning and lubricating, constant supply of pericardial fluid. But in certain situations, those outlets of the pericardial fluid get blocked. And so you get this buildup of fluid. Patient starts to get this low blood pressure from poor cardiac filling, and eventually shock and death if untreated. All right, short-term memory check. How will this pericardial effusion affect cardiac output and blood pressure? Will both lower, both increase, or there'll be no change? I just told you, so both will lower, because with the heart itself, the chambers being compressed, they are unable to fill with blood return from the systemic circulation. So the blood pressure drops. This is a axial cut on an MRI scan showing the heart, and this arrow is showing the pericardial sac and the buildup of pericardial fluid, making the heart very small. Patients present with low blood pressure, but a compensatory increased heart rate, which is the term tachycardia. The causes can be like after a heart attack, because it causes inflammation. You can have after heart surgery. You can see this. Cancer metastases, breast cancer is the most common, that will obstruct the outflow of pericardial fluid. And then some autoimmune disorders, lupus and rheumatoid arthritis, can also cause a pericardial effusion. And the treatment for this is called a pericardial window. Well, it's essentially creating a new hole in the pericardium to allow it to leak out. So this term cephalad, meaning towards the head. This right here would be the sternal notch. And this is just a marker coming down, marking the center of the sternum. So under local anesthetic, this patient is very, very lightly sedated, because if you put them under general anesthetic, they can have hypotension and die right on the spot. So this is done under local, and then when this pericardial effusion is released, at that point you can go ahead and give them heavier IV sedation or general anesthetic. But the most important thing is don't allow the blood pressure to fall. So let's look inside the heart. This is a slice of the heart, one type of a slice showing the four-chamber view. Above here, the left atrium, mitral valve, aortic valve, the left side. This is the left side of the heart. Notice how the left side of the heart is thicker. It's a higher pressure chamber. And on the right side of the heart is the right atrium with the tricuspid valve. And you can't see the pulmonic valve in this cut. So remember, the blue is depicting deoxygenated blood. Blood is coming to the heart from the systemic circulation. These nodes are part of the conduction system, which we'll get into in later presentations. So the right side of the heart is the right side of the heart is low pressure because it's coming from the systemic circulation. So there's nothing pushing that blood back. And then the left side of the heart is the high pressure situation, the high pressure pump. This is requiring to be high pressure so that it can distribute oxygenated blood to the very extremities, including your toes. And within that heart are all these one-way valves. On the right side of the heart is the tricuspid valve and the pulmonic valve. The left side is the mitral valve, also a bicuspid valve. The only valve that's bicuspid is the mitral valve. And then the aortic valve on the left side. The intention of these valves are one-way valves intentionally to keep the blood moving forward. So in order to keep them forward, for instance, this one is showing on the left side of the heart, when the mitral valve is open, the aortic valve has to be closed. So that when all that blood comes into the chamber can fill, and then a cardiac contraction, the aortic valve opens and the mitral valve is closed. All right, so this is a plastinated human heart that's in the lab, and it's cut in a funny way. It's a very unusual way. But I want you to look at the image and see if you can figure out which side of the heart, which chambers represent are actually the left ventricle and which is the right ventricle. So knowing that the right ventricle generates lower pressure, which chamber, which letter represents the right ventricle? The answer is Y. Notice how this wall, this ventricular wall, is so much thinner than the wall of the X chamber. So that's the left ventricle. This is the left ventricle. So this is cut right down through the ventricles. And up here are the atria. And of course, the aorta coming up the top. And this is the pulmonic artery. So why deoxygenated blood, thin wall, low pressure? It has to be low pressure because if it's taking the deoxygenated blood to the lungs, and the lungs has to be a very low pressure system because it's only the alveoli are only one cell layer thick to allow for oxygen exchange. So you have to keep the right side of the heart low pressure and the lungs are low pressure. In contrast, the left ventricle is high pressure, so it has a thicker wall and has to be a higher pressure to get that oxygenated blood to all the body cells. So disease presentation, hypertension. What does this do to the heart? So hypertension is where these arteries coming from the left side of the heart become less distensible. And with that less sensibility, the left side of the heart has to work so much harder to overcome this pressure. So in chronic hypertension, you'll start seeing this left ventricle getting thicker and working harder. So the muscle is having to work harder to overcome this um, blood pressure. So next question, forward flow. The aortic and mitral valves are most commonly replaced. Personally, in 35 years, I have never seen a tricuspid or pulmonic valve replaced. I'm sure that happens, but in my experience, I haven't seen that. It's very rare. So what happens when just one of these fail? Either the aortic or the mitral valve fail? Does it hurt the lungs or does it hurt the liver? Okay, so think about forward flow. What happens? Where does it go if it goes backwards? And the answer, it goes back into the lungs. That high pressure gets pumped, that high pressure heart pushing oxygenated blood backwards. So if blood is not moving forward in left heart failure, it backs into the lungs and causes leakage of plasma into the alveoli of the lungs. Right heart failure, if it backs up, you'll start seeing liver damage, pedal edema, which is swelling of the lower extremities. So lung physiology, it's a very low pressure system, got that capillary network. And so all you have to do is have failure of one or both of the valves off the left side of the heart, causing buildup, and fluid collects in this alveoli, and then you lose oxygen exchange. This is a case presentation. This is in a low resource setting. This woman, although it's hard to tell that she's pregnant, she's extremely, extremely thin. She's been there for several weeks when I showed up, and had already had the removal of her left breast for an infection. Wasn't sure if it was tuberculosis or cancer. Most likely it was tuberculosis that had gotten into the breast. So she was coming to the operating room for frequent washout and cleaning. And this fluid is that's on there, this orange fluid, is called betadine. It's an iodine containing solution to kill bacteria. And that's why this is not blood, this is a fluid of iodine. So she wasn't doing well, and although her infection seemed to be improving dramatically, but she was getting sick, and finally she quit eating, and she collapsed when she was standing, and she passed her mucus plug, which is a mucus that collects at the end of the cervix. And when that passes, it's usually a sign that pregnant patients are getting ready to deliver. Her heart rate is really fast, and so tachycardia, heart rate of 140, which is high for an adult. And so I did an ultrasound, and this is just with my nerve ultrasound, but I was able to get this 4-chamber view surface echo. And did a recording. So this is a 4-chamber view. This is the right atrium, left ventricle, or right ventricle. What you're seeing here is this big vegetation that's hanging on the mitral valve, the anterior leaflet of the mitral valve. So this is a still picture of the 4-chamber view, showing this anterior leaflet of the mitral valve, this vegetation. So since she was getting ready to deliver, And she was also looking like she was doing extremely poorly. Was decided to go ahead and do a cesarean section, a fairly emergent cesarean section, first thing in the morning. The diagnosis is endocarditis. Endo means inside the heart. So it's an infection inside the heart with the infection growing on the mitral leaflet. So why this would be such an emergency? If something breaks off the mitral valve, you have to think of where it might go. Now I've labeled all these different options. Where would it not go? It would go to all these places except for one, either the brain, lungs, extremities, or gut. Where would it not go? And the answer is it's going to go forward because all the blood is pushing it forward. It's going to break off and likely go to the brain. It could go to the extremities. The one place it's not going to go is into the lungs. So she could have a massive stroke. These are all the places it could go. So the brain, extremities, could go in the intestines, but the one place it's not going to go is backwards into the lungs because the valve, although it has this massive vegetation on it, still the blood is moving forward. So in the morning, I came around just to see if actually if the baby was still alive is what I wanted to see. And since we didn't have any fetal monitoring, I decided to use my ultrasound that I use for my nerve blocks. And what it showed is that the heart rate of the baby was very slow. Now, fetal bradycardia, 100 is very low for a baby. A baby should be much higher. In the adults, it's completely different. So a heart rate of fetal bradycardia of 100 shows that the baby is not doing well. The mother seems a little better. She's not, she had been started on antibiotics. Her heart rate was down, her blood pressure was good, and her lungs were clear. So saying that their lungs were clear, meaning that their heart valve is still functioning normally, although it has a vegetation on it. So on fetal ultrasound, I'll show you this little image, this little video. You can see the baby's heart rate is very slow. This is showing the, actually, this is the baby's heart. This is the baby's vertebra. You can see, actually, that's the baby's mitral valve. So the baby is in fetal distress. A healthy fetal heart rate should be 120 to 160. So continuing on, the next morning, the mother is doing very badly. She's got a high temperature. She's not responding. Her blood pressure is very high and her heart rate is very high. And now I'm thinking she must have broken off something that went to her brain and thinking that she might have had a stroke. But then 3 days after surgery, the mother wakes up, and I would show you her eyes, but I need to make sure I keep a little anonymity. So she's awake. She doesn't show any signs of a stroke. She's starting to eat and drink. The baby's also getting better. The baby's getting formula feedings, a little bit of oxygen. This is I don't want to say neonatal ICU because it's very low resource setting. So they did have oxygen, although notice that this is an adult oxygen cannula. And since there was no clothing available, the nurses took bandages and used them to make a little hat and make a little shirt for the baby. So this is 3 weeks later. Patient's been on the antibiotic vancomycin. This she responded dramatically to this specific antibiotic, and I couldn't find any endocarditis. This view looks a little different from the other view. This is the best I could get with my ultrasound, surface ultrasound, but there's no evidence that there's a vegetation anymore. All right, let's do a quick quiz. Which one of the heart valves has only two leaflets? Tricuspid on the right side, pulmonic on the right side, mitral on the left side, or the aortic on the left side? Answer is the mitral, also called the bicuspid valve. This is looking at the heart from above. So the anterior, this would be anterior up at the top of the screen, posterior back. So this is actually how the heart is laying in the chest if you're looking from above. So the mitral valve is down here, bicuspid. Tricuspid valve, pulmonic, aortic. The best way to remember forward flow and the valves is remember this mnemonic: try pulling my aorta. T stands for tricuspid, pulling, P stands for pulmonic, M mitral, and aorta, aorta, aortic. Okay, another case scenario. You're an anesthesiologist during an operation. The surgeon looks over the drapes and says, "Is the patient still breathing? The color of the blood has changed." So what is the color of deoxygenated blood? Is it blue, bright red, or black? So the answer is it's very dark, dark red or nearly black. So in all of these images, I just want to point out that deoxygenated blood is always represented by blue, just to make it clear of what is deoxygenated and what is oxygenated. So in reality, oxygenated blood is bright red and deoxygenated blood is either dark red or black. So next case presentation. This is a presentation. This is in the US here. This is a 65-year-old woman who was transferred from another hospital. She had a past medical history of smoking and COPD, chronic obstructive pulmonary disease. She came into the ER and she was in respiratory failure. She was intubated and she was placed on a ventilator. And during her exam, they noticed that her right arm had no pulses. So because her arm has no pulses, the clot is located right in this area, or the obstruction. It's either a clot, embolus, or an obstruction. So the brachial artery splits right at the elbow to become the radial or the ulnar artery. The way to remember that, the radial artery follows the radius, ulnar follows the ulna, and of course the palmar. So if she had just a clot down here, you would still get a radial artery pulse. So on EKG, they noticed that she was in atrial fibrillation, meaning that her she was not having coordinated contractions of her atria. So a blood clot formed in her atria. So which atria did it come from? Which atrium? Either the right atrium or the left atrium, to be able to get a blood clot all the way down to your arm? The answer is came from the left atrium. So look at this schematic. a blood clot in the left atrium comes out here and goes into, it certainly could have gone to her brain, which is very fortunate it didn't. So it goes to the extremities, could go to the intestines. I've seen that before. And this is surgery. This is a little video I took of the actual surgery of, this is her right arm, and this is taking the blood clot out of that brachial artery. And before I get started, what I'll show you is the surgeon is taking what's called a Fogarty catheter, and he'll put it into the artery, blow up the balloon, and then drag the clot out.
The catheter that has a balloon on the tip of it that you can inflate. The tension will displace the catheter into the artery. That's part of the blood clot right there. The artery is filled with clots, so we're going to pass it up through the clot and above the clot, and we're going to pull the clot down to us. We have a gentleman, Dr. Toby, invented this when he was a medical student, so if you guys are inventing stuff, you're not doing much. If I can pull it back, you can see much clot come out. That's the big clot.
So afterwards, after taking out the clot, they'll do a fluoroscopy and arteriogram, injecting some dye to look at the system to see if there's any obstruction, if all the blood clots have been removed. So he's going to go through a little bit of the anatomy.
So this is the axillary artery, a little bit of disease narrowing in there, but nothing dramatic. This is the internal mammary artery. That's the vertebral artery. This is the subclavian artery. This is the innominate artery, and this is the carotid artery going up. All the thrombus has been removed, and we're done.
So any questions, please leave comments. The PDF will be, a link for the PDF will be included as well under the description. And I thank you.